This conference will now be recorded.
Yeah, good evening, everyone. This is Sadat. I am taking a session on peritoneum today. Let's directly jump into it. Okay, first of all, I want to define what is peritoneum. Okay, what is peritoneum? Peritoneum is a serous membrane. Okay, it is a serous membrane lining the abdominal cavity. Okay, lining the abdominal cavity as well as the organs. So, what does this serous membrane consist of? It consists of a fibrous layer as well as mesothelium. Mesothelium. Now tell me, what does mesothelium do? Mesothelium secretes fluid. Okay, it secretes fluid. So what is the purpose of secretion of this fluid? It helps in lubricating the abdominal cavity. It helps in lubricating the abdominal cavity so that the organs are mobile. Okay, so that the organs are mobile. So God has given this mechanism to us, right? We have bowel movements, we have all these movements, right? So we have peritoneum, which consists of this mesothelium, which causes the lubrication. Okay, because it secretes fluid. Till here you have understood what is peritoneum. You have understood, right? Serous membrane, nothing much. Now, I want to explain you with an example what is peritoneum and how it is formed. Now, consider this as a spongy ball, okay? A spongy ball. Now, what I'm doing is, this is a viscera. This is a viscera, meaning this is our abdominal organs, okay? Viscera means abdominal organs. Now, this abdominal organs, what I'm doing is, I am taking this and pushing it into the spongy ball. Now, consider this spongy ball as a peritoneum, okay? Consider this spongy ball as peritoneum. Have you understood till here? Simple, nothing much. Now what happens from this? Let's transcend to the further stage. What happens is, this spongy ball will take in the orange object, which is nothing but our abdominal viscera. Okay, abdominal viscera. It will take in the abdominal viscera, and this thing will go inside like this, and it will be like this. Have you understood till here? Have you understood here? We have done nothing but push the abdominal viscera into this spongy ball, and the spongy ball, what it did is it just took the abdominal viscera into itself. Did you understand till here? Did you understand till here? Nothing much is there. Okay, consider this abdominal viscera as a hand. Okay, this is a famous example. Everybody will use this. This is our hand. What we are doing is, we are taking a balloon. Okay, this balloon, what we are doing is, we are taking this hand and we are pushing it into the balloon. So what will happen now? Just consider your perspective, your vision of view. This above diagram, we are viewing it from the top. Okay, from top I'm viewing it below, right? From top I'm viewing it below. So suppose I'm like this, and this is how we are viewing it right now in this diagram. In this diagram, how are we viewing it? We are viewing it as a side image, right? We are viewing it as a side image. Did you understand till here? So now, in the top image, what I want you to focus is, I am going to label this. I am going to label this for a better understanding. Pranav, just tell me if they have any doubts till here. Just any doubt. Just, it's a simple thing.
No doubts, Sadat, but I just want to tell that why are you not encircling the gut? I mean, that orange thing,
Yeah,
isn't that encircled on all
yeah,
the
yeah. I'm
sides
coming
with
to
it?
that. From the hand diagram, I'm coming to that. Yeah.
Okay, okay.
I was coming to that. Okay. So now focus over here, everybody. What I'm doing over here is, once we put our hand like this inside, now imagine the hand coming inside like this. Have you understood this? Yes, you have understood this. So now, when we are putting our hand inside, what is happening is, this peritoneum will go inside like this. As Pranav told, I have not mentioned over here. So focus over here clearly. So now what I'm doing is, I'm doing nothing. I'm just labeling this peritoneum into two parts. So the part which is not touching the viscera, that is the orange object, I'm naming it as parietal peritoneum. And the part which is encircling the viscera, I'm giving the name as visceral peritoneum. Did you understand this? Simple, right? If it is encircling the viscera, visceral peritoneum. If it is not encircling the viscera, only the outer abdominal wall it is encircling, then it is known as parietal peritoneum. Now, another thing we have to give a name is that the part of the peritoneum which is holding the viscera, okay, which is hanging the viscera, which is holding the viscera, we are giving it a name as mesentery. Mesentery. Did you understand till here, everybody? What is parietal peritoneum, which does not encircle the viscera and it is covering the other part of the abdominal wall. Okay, and this visceral peritoneum is nothing but which encircles the viscera, that is the abdominal organs. Okay, and the part of the peritoneum, which is hanging the, which when encircled inside the balloon, which hangs this part, this hanging part, or this part, as you can see, is given a name as mesentery. Okay, so anything which is consists of layer of peritoneum, we are giving a name as mesentery, right? Okay, did you understand till here? Parietal peritoneum, visceral peritoneum. Okay, for your understanding, I have brought two images. Here we go. Now see, you see in this diagram clearly, right? This is our vertebra and all that. We are not going into this, right? Now focus on the blue cavity as well as the orange colored thing. Now come over here. What do you see? Tell me. Yes, this pink colored. Okay, one second. This pink colored thing is known as our parietal peritoneum. Okay, as well as if I give a slight color to our easy understanding. Okay, over here, this part which encircles this part, this green part, we are giving a name as, tell me, visceral peritoneum. Okay, apart from the visceral peritoneum, this part which is hanging the viscera is given the name as mesentery. Till here, did you understand? Right. Well, now what is that blue colored space given over there? What is the blue colored space? Yes, the space between the parietal as well as the visceral peritoneum, we are giving a name as peritoneal cavity. Peritoneal, let me just zoom out so that you understand the handwriting. Peritoneal cavity. So the layers occupying the space in between the two layers is known as peritoneal cavity. Have you understood till here? For a simple understanding, again I'm showing another diagram with the hand. Do you see the hand? Yes, the hand is pushed inside the balloon. Okay, now this rest of the part is known as the parietal peritoneum. Let's go back. Okay, and let's go back. Let's remove this now. And the part which is covering the, and the part which is encircling this hand part, this part which is including the abdominal viscera is known as the visceral peritoneum. I think this is understood. Okay, did you understand with the two examples? Up till here, did you understand, everybody?
Yes, Sadat, they understood. But Sadat,
Yeah,
can you please
very good,
just
very good.
revise everything in 30 seconds because there are few people who joined late. So it's a very important
Okay,
concept and
okay,
you're explaining it in a very nice way. So I just hope they don't miss
sure,
out on something important. Yeah.
sure, no problem, no problem. Okay, so now what I have done is, everybody who have come late, see, this is our spongy ball or our balloon. Okay, what is this balloon? We are viewing it from the top. We are viewing from the top. Suppose I have taken you and I've made you fly in the air, and you're looking at something from the top. Obviously you know this view, right? And this is our ball we are viewing. Now from this ball at the top which I'm looking, what I'm doing is I'm giving this name as, this is our peritoneum. Okay, I've already given the description of peritoneum. Peritoneum is nothing but a serous membrane or a serous layer consisting of mesothelium which secretes fluid so that our abdominal cavity gets lubricated for our abdominal organs to be mobile. Okay, it's a natural mechanism which God has given us. Okay, now in this peritoneum something interesting is happening. What I'm doing is I'm taking the viscera. This is known as the viscera or nothing but our abdominal organs. What I'm doing, what is God doing actually? This viscera during the development, what will happen? This viscera will push inside the peritoneum. So now this peritoneum, what happens is, this is a elastic ball. I told you, elastic or spongy ball. So what happens is, when the pink object or our viscera is pushed inside the peritoneum, what happens is it goes inside like this. Okay, now what will happen is this peritoneum will extend like this and it will cover like this. Okay, now what we humans did is we have given names to the parts of this peritoneum. Till now you have understood, right? Yeah, what are the names of the parts? The part which is covering this viscera is nothing but our visceral peritoneum. Okay, and the part which is not covering the viscera and it is only covering the abdominal wall, the rest of the abdominal wall, we're giving a name as parietal peritoneum. Okay, and the part which is hanging or controlling, okay, I can say it is hanging the viscera into its from the posterior part, which is hanging it, or which is the layers, the two layers which are engorging the viscera. I'm giving these two layers together a name as mesentery. Okay, mesentery. Now mesenteries don't stick to mesentery very specifically. When we go further into the session today, mesentery's meaning will change a bit, so do not worry, don't focus on mesentery for now. Focus on the visceral peritoneum, which engulfs the viscera, and the parietal peritoneum, which engulfs the abdominal wall. Okay, I think I've covered that. Now these were the two diagrams I had shown. Okay, this is the hand, balloon. Okay, now let's go further. For your theory exams and for your viva, they may not ask this, but you have to have an understanding of the difference between the parietal peritoneum and the visceral peritoneum. Note down this, guys. Note down this. Yes. The first point I want to tell you is that peritoneum, the parietal peritoneum and the visceral peritoneum. In the parietal peritoneum, its covering is very simple. Okay, it's very simple. This is understandable, and this is very complex. Okay, now parietal peritoneum is derived from, as you have already listened to the lecture of Arbaz, somatopleuric layer of the lateral plate mesoderm. Lateral plate mesoderm. Did you understand this, my friends? Where is it derived from? Somatopleuric layer of lateral plate of mesoderm. If you see here, embryologically, this is derived from? It's derived from the splanchnopleuric. Oh, sorry for the mistake. Let's forget that. Splanchnopleuric layer of lateral plate mesoderm. Okay, lateral plate mesoderm. Did you understand the 2 points? Yes. Another very important point apart from these 2 points is that the parietal peritoneum is sensitive to pain. Yes, note this down, everybody. Note this point down, or take a screenshot if you want to. One second. Yeah, sensitive to pain, whereas this is not sensitive to pain. Okay, you have to know this. Okay, I think we have differentiated very nicely. You may ask me why. Because here it is supplied by the somatic nervous system, and here it is by the autonomic. Okay, autonomic, parasympathetic, and all. Okay, so now sensitive to pain is the parietal peritoneum, and not sensitive to pain is the visceral peritoneum. Have you understood the difference? Simple, complex, somatopleuric, splanchnopleuric, sensitive to pain, not sensitive to pain. Let's jump into our next part of the session. Okay, we are done with the basics. Now let's come to the next part of the session. Now remember, I have put in the WhatsApp what all the pro forma of today's session. Yeah, the next aspect of today's session is about the classification of the folds of the peritoneum. Yes, now we are coming to the interesting part. So now, before I come into the folds of the peritoneum, just remember, in the abdominal organs, anything which is covered by the peritoneum, we will call them as peritoneal organs. Okay, nothing much is there. Simple, peritoneal organs. But the organs which are not covered by the peritoneum, or the organs which are only covered by a single layer of peritoneum, we are giving a special name to that, known as the retroperitoneal organs. Did you get this? Retroperitoneal organs. Okay, retroperitoneal organs. Now, what you may ask me, what are the retroperitoneal organs? I will be drawing a very important diagram after the basics right now, just in a few minutes. You have to memorize that diagram, and you have to draw it in every aspect. If whatever they ask in your peritoneum, you have to draw the diagram. Okay, it's a very crucial diagram, and there also we will cover about the retroperitoneal organs. Okay, now about the classification of folds of peritoneum. Now, in the folds of peritoneum, what are the other aspects of, what are the different names of the folds? Okay, there are 3 names. Okay, there are 3 names given to it. First name about the folds of peritoneum is omentum. Okay, first name about the fold of peritoneum is omentum. Now another aspect of the peritoneum is given as ligaments. Okay, ligaments. Lastly, another thing is known as mesocolon. Okay, mesocolon or mesentery. Here again mesentery is coming, so now you have to focus over here. Now, the most important aspect for today's class is the confusion about the omentum. Most of the people get confused in the omentum. So we have to clarify very nicely about the omentum. Now, what have we discussed? What is this we are discussing? This is the folds of peritoneum. So the folds of peritoneum is divided into omentum, ligaments, as well as mesentery. Okay, mesentery. 3 aspects. So we will be going in detail about these 3 aspects, right? So what is omentum, you may ask me? Okay. Now before now, did you understand the folds, the three names of the folds? Okay, now this is over. Now we will be going to the most important aspect of today's session, is the diagram. Okay, I want everybody to draw this diagram. I want everybody to draw this diagram. Please, you have to draw this diagram. Even if you're sitting nicely, just draw the diagram, okay, roughly. So now presently we have this boy present over here, this man present over here. What I'm doing is I'm taking a sagittal section, meaning what I'm doing is this is his right and this is his left. I've divided this fellow into half. Now we are viewing this fellow from the lateral aspect after dividing him. So sagittal section, you must know this, right? So if this is the anterior and this is the posterior of the person, we are taking that anterior and posterior and we're putting here. This is anterior, this is posterior. Okay, did you understand this? Yes. So this is our anterior abdominal wall. This is our posterior abdominal wall. Have you understood this? This is the sagittal section. So I've cut this person into half. Now we are viewing very important, very important. Draw this diagram, everybody. The positions of the organs is very important to understand this concept. So first, after cutting the body into half, first our liver will come over here. Our liver will come over here. Did you understand this? I'm going to label it very nicely. Yes, this is our liver. Okay, our liver will come over here. Next, what will happen is just below the liver, a little bit not posterior, just below the liver, we will have our another organ. This is our stomach. Okay, stomach, I'm putting S. Okay, exactly a little bit posteriorly, we will have our transverse colon. Okay, now behind the transverse colon, we will have our pancreas. Yes, this is our pancreas. So pancreas will be present posteriorly, almost very posteriorly. Okay, it will be attached posteriorly. So did you understand this? From anterior to posterior, what is there? Initially above, liver is there, then stomach, then behind it is transverse colon, lastly behind it is pancreas. Till here, did you understand? Let's go a little bit below. Below the transverse colon, I will draw another aspect of our. Yes, this is our small intestine. Did you understand till here? Yes. From anterior to posterior, I'm drawing. It's a broad spectrum diagram so that you have a good understanding of the peritoneum. Now we have, if you go very below, what will happen anteriorly? What we will have, guys? Yes, we will have the urinary bladder. Did you understand this? Now, in females, what will happen is, in females, you will have the, yes, you will have the uterus. But I will not draw it over here. Okay. You will have the, oh, this diagram is very huge. Okay, I will draw it somewhere else. For now, I'm omitting this. Okay, for now, I'm omitting this. Let's remove this. Yes. Now, behind the uterus, what is there? This is our rectum. Okay, this is our rectum. So, rectum. Did you understand this? Okay, let me draw this here only so that this is in the females. Okay, don't draw in the males when you're putting in the exam. Okay, so this is our. Yes. Now, everybody focus over here. Why am I drawing all these diagrams? Why is he drawing all this? Yes, because you have to differentiate what layer of parietal peritoneum is present where and where which visceral peritoneum is present where. Okay. Now focus very closely over here. Yeah, I forgot about this. Here we have our, one second. Here we have our kidney. Okay, kidney. This is our kidney. Okay, till now did you draw this diagram, everybody? Yes. Now take out two sketch pens or two color pens. Now carefully draw this diagram. Now I want you to focus very carefully over here. Now from the liver we will start. This is our parietal peritoneum. This fellow is okay. I'll draw it a little bit bigger. Yes. This is our parietal peritoneum. This fellow is coming over here. He's going down, and then he will go near the urinary bladder. He will cover the urinary bladder from above, and then he will form a pouch like this. Okay, just follow with me with the diagram. I will label everything. Do not worry. This is in the female, so this we can omit afterwards. Not a big deal. And then we have the rectum. Near the rectum also another pouch is formed. This is the parietal peritoneum only. You are in the parietal peritoneum only now. Now this fellow will go like this behind the rectum. Okay, he will go like this and he will not cover the kidney. He will go behind like this. He will go straight and he will look. Oh my God, small intestine is there. I left the small intestine. He will again go to the small intestine. He will cover the small intestine like this and he will go like this. Again near the pancreas, he will tell, I don't want to cover you. Never mind. And then he will go like this. Below the transverse colon, he will go like this and greater curvature of the stomach is covered. Till here, did you understand? Till here, did you draw the diagram? This blue colored thing which I have drawn is the parietal peritoneum. Okay, now I want you to focus over here. Here, what will happen is, I told you to revise the gross anatomy of liver and stomach, right? You must have read about the bare area of the liver. You know why it is called the bare area of the liver? Because the peritoneum is not covering over here. Peritoneum is not covering over here. So what happens actually over here? What happens is nothing, but it goes like this behind. Yes, it goes like this near the liver. It will go behind. Now exactly like this below, and then there you go. It covers it like this. Did you understand till here? Pranav, just let me know na if they have understood the first drawing.
Yes, Sadat, they've all understood.
Very good, very good. Now I'm giving a name to this. What name should I give to this? I think I should show you what name it should be given. We have named this as the greater sac. We have named this as the greater sac. Okay, we are done with this. Now I want you to come to the other aspect of this. I'm going to draw it with green. Okay. Now what happens is, we have left the other side of the bare area of the liver. Did you see the bare area of the liver where I have drawn the yellow? Yes, this part. Here again, there is another parietal peritoneum. Now, we have not left that. So this parietal peritoneum will come like this, go down like this. It will go behind like this. Okay. Okay. Yeah, 1 second. I have made a mistake. Let's rub this greater sac. Let's rub this greater sac. One mistake I have made. Do not worry. Yeah. Just improvise the diagram, my friends. Yeah. So this peritoneum which is going in anterior part of the stomach, okay, near the anterior part, it will go below like this. It will go below like this, and then it will go like this. Okay, it will go like this and it will join like this. That's one mistake I've done. Okay. Okay, did you understand this? Yes. Now come to the green aspect. Green aspect. What does this green aspect do? This green aspect fellow, he will go like this. Again, he'll go with his friend like this. Friend, it will go like this. He will go anteriorly to this transverse colon. It will go, he will say, no, I don't want pancreas. He will go like this. He will not cover the pancreas. And now he will go above and he will join off with this fellow. Did you understand the second part of the green diagram which I have drawn? Do draw this diagram, my friends. I had made this mistake, right? Yeah, draw that extended part. It's very important. Okay, so now I have to give another name. What is the opposite of greater? Lesser. So this is the lesser sac. Did you understand that? Lesser sac, greater sac. Now we have drawn the diagram. Okay, you have labeled the greater sac and lesser sac. I will be describing everything, what is lesser sac, what is greater sac. For now, just draw this diagram, label the diagram for your understanding. Okay, now we are coming to the interesting part. Remember, I have told you wherever there is layers, what we have to give names. Okay, we have to give names to the layers. Now what we have to do is one interesting thing we have to do. Let's just rub this greater sac and lesser sac. Okay, now we are going to label this diagram for your easy understanding. Now be with me, guys, be with me. Now you see this 1 2 3 4 layers. I'm giving a name as, I'm telling you that these are 4 layers. Okay, now what I'm doing is, together these 4 layers, I'm giving a name. What name should I give? Yes, I'm giving a name called as greater omentum. For now, just draw the diagram, be with me. I will show you the anatomy of the diagram. I have photos also. Okay, so now did you understand the 4 layers of the greater omentum? See, from the stomach, those 2 layers are going down. Okay, so now what I'm doing is, I'm just labeling these numbers. What I'm doing is, I'm giving 1 2. Now this 2 will become 3. It will go backwards. So this 2 will become 3 and this 1 will become 4. Did you understand the greater omentum, my friends? Pranav, just let me know now if they have understood the greater omentum.
No answers. Yeah, they've understood, Sadat.
Yeah, great. Okay, now what is the opposite of greater omentum, my friends? Lesser omentum. So now lesser omentum, where should I put? Focus over here. Be with me. Now in the just above the stomach, look, just above the stomach to the liver, you see 2 layers. These are the 2 layers I'm talking about. You see these 2 layers? Yes, we will give this as the name as lesser omentum. Okay, now tell me, greater omentum has how many layers? 4 layers. Lesser omentum has how many layers? 2 layers. Okay, just be with me. I will explain what is the concept. Why are we telling it as 4 layers and why are we telling it as 2 layers? Okay, Lesser omentum 2 layers, greater omentum 4 layers. Now we have labeled the omentums. Okay, we have labeled the omentums. Now let's go to the I will just explain the mesocolon so that you understand what is transverse mesocolon. Yeah, so now let's come to the classification. Are we done with the omentum, my friends? Are we done with the omentum in the labeling? Yes, we are done with the omentum. Now let's just finish off with the mesocolon, and then ligaments is a little bit complicated. I will go and explain it in a detail. Okay, man. So now, what is the transverse colon? Tell me, my friends. Is you see the TC over here? Yes, this is the TC, transverse colon, just behind the stomach. Okay. So now, not just behind the stomach, it will be a little bit down also. Just for your understanding, I've drawn it in a pictorial manner. Okay. Now tell me what is the layers which is holding the transverse colon? Tell me. You see these two layers? Aren't these holding the transverse colon? Aren't these two layers engorging the transverse colon around it themselves? Yes. So I'm giving another name. I'm giving them the name as these two layers. I'm giving the name as transverse mesocolon. Okay, mesocolon. As mesentery we told, na, we'll give a name as mesocolon around the colon. Okay. Yes, we have done with the colon also. We are done with the mesocolon also. Ligaments, I will explain in a minute. Let's label the other aspects of the diagram so that we do not get confused. Okay, when we go in further aspects. So now remember I have told you about the pouches. Remember about the pouches I have told you? You remember, right? So now let me tell you that in females, when we draw the uterus in the females, where you see this is the female. Just in males, what will be there? In males, only urinary bladder and rectum. But this is the males. In females, we have the urinary bladder, the uterus, and the rectum. So now, let's just forget about the male. Look over here in the females. Very important aspect. I'm telling. Nobody will remember this when asked in the Viva. I don't know why. Look at these pouches. This is one pouch I'm telling, and this is one pouch I'm telling. Now, what name should I give to this pouch? See, you should give the name to the pouch to the position. Okay. So, urinary bladder, what is the technical name or the medical term we give to the urinary bladder? Vesicle, right? So, vesicle. Now, what do you see here? Uterus. So, what will we give? What name can we join and tell? We will tell as vesico-uterine pouch. Yes. Label this, my friends, please. Vesico-uterine pouch. Did you label this? Very good. Now, another aspect again, very simple. This is the uterus. This is the rectum. What name should I give? Recto-uterine pouch. Okay. Another name for this recto-uterine pouch seen in females is Douglas pouch. Okay. Very important VSAQ. It had come to us in the finals. So now this Douglas pouch, just write it down over here. I'm telling you, right? This diagram is very important. We will be coming to this diagram all the time. Do not worry. Just label the diagram and that's all. That's all I want from your side. Then I will explain all the concepts. Okay. So what are the two pouches? Vesico-uterine, recto-uterine pouch. Recto-uterine pouch, another name, Douglas pouch, which is a very important VSAQ seen in the females. Okay, seen in the females. Now, in the males, nothing much is there. In the males, what will be there is this is the urinary bladder, right? Urinary bladder, and then we have the rectum, right? So only one pouch will be there. Only one pouch will be there like this. So this pouch will be named as vesico-uterine. Vesico, not uterine. Vesico-rectal or rectovesical pouch. Rectovesical pouch in males. Okay. I think you have understood till here. You have understood the pouches. You have understood the mesocolon. You have understood the omentums. Understood meaning? You have understood the labelings, where it is present and how it is there. Okay. If you have understood, it's great. Now I just want to add one last point and then let's go into the concepts. Okay. Now I want you to focus over here. I want to tell you that the greater sac and the lesser sac, meaning the blue drawing of my diagram and the green drawing of the green part of the diagram, both communicate with each other. Both communicate with each other through a foramen. Okay, through a foramen. Now remember, don't get confused. These two layers as a sum is known as lesser omentum. But the communication between the lesser sac and the greater sac, there is a foramen like this. Foramen like this. Okay, foramen like this. What is the name of the foramen? Foramen epiploica. One second. Let's just rub all this. Be with me, my friends. Let's just rub all this. Yeah. So foramen epiploicum. Okay, epiploicum or epiploica. Okay, another name for this foramen is foramen of Winslow. I will explain this also. It's a very important question. Foramen of Winslow. So what did I tell you? What is the use of this foramen? It is the communication between the lower sac and the greater sac. Okay, I think you have understood till now what is the omentum, what is the transverse mesocolon, what is the parietal peritoneum, how it is folding, how it is happening in our body. How is, you told that there is engulfing of the hand into the balloon, but how it is happening in the diagrammatic way, this diagram shows nicely. Okay, do you understand till here? Pranav, just let me know if they have understood till here, then I will jump to the ligaments and then let's go further.
Yes, Sadat, they've understood.
Great. See, I have cross-sectional diagrams for you guys. See, this is the cross-sectional diagram. Okay, cross-sectional diagram, right? We cut the body into this is the body. So we have cut the body into half like this, and we are seeing. So now, so how we are seeing is this is the posterior aspect. Oh, sorry. Yeah, this is the posterior aspect, and this is the anterior aspect. So now, yeah, wait second, one second. Cut section. Yeah, sorry. Yeah, this is correct, I think, right? Yeah, it's correct. So now when you look over here, the blue colored aspect of this diagram, do you see all this blue colored diagram? You see or not? Yes, this whole blue color diagram is known as the greater sac. Okay, greater sac. Okay, now let's go below in the next diagram. Yes, do you see this yellow colored aspect of the diagram? Yes, this diagram, yellow color aspect of the diagram. Yes, in this yellow color diagram, what we are naming this as the lesser sac. It is the cross sectional diagram. Okay, so if I think in the cross sectional also, if you are getting another view for understanding, it will be easy. Otherwise, that sagittal section diagram is more than enough for your understanding, I think. Okay, this is the stomach, this is the liver, this is the spleen. Okay, now we'll go to the ligaments and then we'll jump into the next aspects. See, what does omenta do actually? Omentum, what it does is it connects the stomach. Okay, it connects the stomach to liver, and it connects what you say transverse colon, right? That's what it does, omenta. See, if you see in the diagram, where is the diagram? Yeah, in this diagram, do you see the stomach, my friends? You see the stomach, right? So what does omenta do? You see the labeling? See the labeling of omenta? Let's put this lesser omentum back over here. What is doing? Omenta is related to the stomach only, na? See below, if you look, I'm just coloring it with yellow. If you see below, it is connecting. This is connected with the transverse colon. So stomach with the transverse colon. Understood? And lesser omentum, stomach with the liver. So what is the conclusion I can tell? Omentum, what does it do? As in when you ask in simple words, if somebody asks you what does omentum do, what is its purpose, you will tell it is the peritoneum which connects stomach to liver or stomach to transverse colon. Did you understand this? I hope you have understood this. Okay, now omentum is yeah, I've defined omentum. What does ligament do? Ligaments, what they do is they connect abdominal organs to each other, or they connect abdominal organs to the abdominal wall. Okay, abdominal wall. So each other or abdominal wall, when there is a peritoneum layer connecting two organs to each other, or one organ with the abdominal wall, we will give a name as ligament. So for example, there are three types of ligaments. Important ones are three, more are there. For now, I'll just name the three ligaments. Gastrosplenic ligament. Okay, gastrosplenic ligament. Okay, lieno-renal ligament. Okay, and then we have coronary ligaments. This I think you have read in the liver. I hope you have read in the liver. So now if we just divide the name, so let me just rub this off now. Yes. Okay, once again. Yeah, so in the name, tell me what is the name? Gastrosplenic, meaning this is our stomach, right? This is our stomach, and behind posteriorly, means more laterally, what will be there? What will be the spleen? This is the spleen, this is the stomach. So gastrosplenic ligament, meaning the the peritoneum is connecting the stomach's greater curvature to the spleen. So this is the gastrosplenic ligament. So I'm giving a name to this whole as a whole as gastrosplenic ligament. Okay. Linorenal means what? Linorenal means spleen is getting connected to the kidney. Spleen is getting connected to the kidney. So let's just rub this off. Yes. In this diagram only watch. In this diagram only watch. When the spleen is present laterally, what happens is below you will have posteriorly you will have a kidney, right? Posteriorly you will have a kidney. So what will happen is the spleen is getting connected with the peritoneum. Certain layers of certain parts of peritoneum will connect abdominal organs, right? Obviously when something is pushed inside, that thing will come in between things also, right? It will come in between also. So we are giving this spleen to kidney one name known as iliorenal. Iliorenal means ilio is for spleen, renal is for kidney. Iliorenal ligament. Okay, have you understood this? Yes. And the coronary ligaments, what does coronary ligaments do? Very, very important ligament. You will have a VSK also in liver. See, if this liver is there, what happens is the coronary ligament will connect it with the diaphragm. I hope you have studied this, right? Coronary ligament, it will connect it with the diaphragm. So something which is connecting the organ with the abdominal wall. So we are giving this name as coronary ligament, right? Okay, coronary ligament. We have falciform ligament. So many
Yeah,
ligaments are there in liver. You
Sadat,
have to know that. LAQ, that is also.
Sadat,
Yeah,
they're saying, isn't it
yeah,
linorenal ligament?
yeah. Oh, sorry, I've written ilio. Sorry, my friends. Linorenal ligament. Sorry. Linorenal ligament. Okay, linorenal ligament. Lino is for spleen, renal is for kidney, right? My bad. I think I've just mixed up the words. Okay, now I think you're done with the. Did you understand the gastrosplenic, linorenal, and the coronary ligaments? Just tell me you have understood. Let's jump into the interesting parts then.
Yes, Sadat, they've understood.
Very good, very good. Now let's jump into our omentum in detail. We are going to write about omentums in detail. Yes, we have only in the diagram what we have understood till now. We have understood that the omentum is connecting stomach, greater omentum is connecting stomach to the transverse colon by 4 layers. Okay, and the liver is connected to the stomach by 2 layers called as lesser omentum. Okay, now we are going to observe this diagram in anterior posterior aspect so that we understand what is the position, what is the attachments. Okay, everything we are going to write. I prefer people to write, all the students to write notes now. If they are writing notes, it will be very helpful. You don't have to read the textbook again. Greater omentum. Okay, greater omentum. See, in Greek or something, omentum is actually, wait, omentum's purpose was what? Connecting stomach to liver and transverse colon. But omentum, when we translate it, it means as apron. Apron. So what is the actual purpose of apron? What does apron do? It covers, or it covers our clothes, or it acts as a, I don't know what word I should use, but it acts as a, front page or a something to describe, like a huge cover, right? Book cover, something like that, right? So apron defines our doctor's aspect, right? It shows. So omentum is also something like that. It covers something, it shows something like a book cover. Okay, so now omentum actually means apron. We have understood that. Now let's come into the, I'll just revise the diagram. This is the liver. Oh, sorry, let's not go to the liver. This is the stomach. This is the transverse colon. What is happening here? First, I'm drawing with the yellow color. The first layer goes like this down, then goes like this posteriorly, like this. Did you understood till here? Still in sagittal section, don't worry. Another layer comes like this, goes like this, covers the anterior aspect. Okay, till you understood here. Now remember, I told you this is the first layer, this is the second layer. Now first layer becomes what over here? Tell me. It becomes the fourth layer. Second layer, what it becomes over here? It becomes the third layer. So now first, second, third, fourth, meaning 4 layers of greater omentum is present. Okay, this is how. First it goes below. Okay, then it folds. Okay, it folds behind. Okay, it folds like this. It folds. So because of the folding, it forms more extra 2 layers. Okay, so now we are going to learn about the attachments. Write down the heading. First write omentum apron. After omentum apron you have written, or first you will write omentum. Omentum is divided into 2: greater omentum, lesser omentum. Now you should write the greater omentum. Put side heading greater omentum. Then another side heading you should write attachments. What are the attachments? Write down. With diagram I will explain. So now, just as in till now what you have understood? Yeah. So this is our stomach. Okay. So what is happening? So what is the superior attachment of the greater omentum? Greater curvature of the stomach. Greater curvature of the stomach. So now this I am putting as superior attachment, right? Now when we go below, you have to write this. First point, superiorly it is attached to the greater curvature of the stomach. Then second point, what you will write? Two layers descend below. After covering the stomach. Then they fold back. You should write this in the note in the exam. Fold back and form the, sorry for the bad handwriting. Fold back and form extra two layers. Okay, so it becomes 1, 2, and then 3, 4. Write this down. Total 4 layers. Okay, then additional point for you to understand what is the greater omentum. What happens is these 2 layers are there. Yes, most of this gets attached, my friends. Still 4 layers are there, but most of that gets attached together. Okay, most of that gets attached together, meaning there will be like this will be very little space, means almost nil space, but a little part will be free at the end. Little part will be free like this, cavity will be there. So this little part, when it goes like this, it will go anterior and then posterior to the transverse colon, right? Write this down also. What you will write? Most of the 2/3 of the 4 layers of the greater omentum is fused. You will write that. Then you will write later this fourth point. You will write that the last layer, the fourth layer, and the third layer. Actually, third layer and 1, 2, 3 are fused very nicely. They will come together like this anteriorly. This 1, 2, 3 will go anteriorly. 1/4 layer will go posteriorly behind the transverse colon. Okay, did you understand the attachments? Pranav?
There are no answers yet. Yeah, they have understood. Sadat, there are a couple of questions.
Okay.
Will you
They are there, right?
answer them now?
Are they leaving off?
No, they are there. But there are two questions, I think. Is coronary ligaments, are they connecting liver to the diaphragm? Do you hear me?
Hello.
Yeah, am I audible, Sadat? Sadat, can you hear me?
Go off.
Sadat?
Yeah,
Sadat,
yeah.
I'm here.
Yeah, okay.
Yeah, coronary ligaments, do they connect liver to the diaphragm?
Yes.
And also they want you to repeat foramen epiploicae.
Yeah, I'm coming. Foramen epiploicum, I have a special diagram for that. I'm coming to that. Just for now, you have to remember what? It will connect the lesser sac to the greater sac for communication. I'm coming to that. That's also an SAQ. Don't worry. Just let me know whether you have understood the greater omentum attachments. Then we will write about the next thing. I think you have understood. Let's jump
Okay,
in the next part.
yeah, they want to repeat the third point, the third attachment.
Third point. Yeah. It's not the attachment. I'm just telling you how to write the attachments. First point, what you have written, stomach greater curvature, it is attached superiorly, right? Then what will happen? You have to write the process of how the attachment is, how the peritoneum layers are going. That's what you have to write in the attachment headings. It's not specific. You have to write how it is moving in the body. That's what you have to write in attachments. Then after the first point, from the greater curvature they are coming, what you will write? Two layers will come down, descend below, right? Descend below. Okay. Then they will fold back and then they will form two extra two layers. Till here you have understood? Yes, they will form 1, 2, and 3 and 4 layers. You have to draw that above diagram only. Okay. Third point, what I have told you is that the 1, 2, 3, and 4 layers in the lower part. So for example, this is the stomach. In the lower part, this is actually completely fused. I'm telling, this is completely fused. Only the upper little part is open. Okay, they're completely fused, meaning they will be like this, very close, very nil space. Okay, that's all you have to write in the third point, that most of the space is closed, most of the layers are joined together. Last point, what you have to write? Yes, last point you have to write nothing. It goes and the third layer goes above the transverse colon, and the fourth layer goes behind the transverse colon. That's all you have to write, attachments. Now we will write the contents of the, very important. So now let me just remind you, see, this is our abdominal cavity. Initially what you will see skin. Remove the skin. After removing the skin, superficial fascia. Remove the superficial fascia. What you will see? External oblique, internal oblique muscles. Remove the external oblique, internal oblique muscles. What you will see? You will not directly see the intestines. You will see the greater omentum. You will see the greater omentum. It will be like this in front of you. Okay, it will be like this in front of you, like that. When you're doing surgery, anybody who wants to become surgeons, when you open the abdominal cavity, you will see, after removing the muscles, you will see greater omentum, and that greater omentum will be will have some patches like this. I'm talking to you when you're removing from forward, okay, from the anterior aspect. So now just look at this diagram and tell me what will be the contents. First of all, the contents, write this down, everybody, take down notes. Adipose tissue. Okay, adipose tissue is a very efficient thing God has given us, that is the peritoneum. It is a very important aspect to store fat. Okay, now very important point in the greater omentum, every teacher will give you extra marks for this. If you write this, write down that there will be milky spots. You see in the gross diagram I have drawn these milky spots. Why are these milky spots coming? Because there are a lot of macrophages God has given us in the greater omentum. A lot of macrophages God has given us. These macrophages are so many that they literally appear grossly when we observe as milky spots. Did you write this? Very important point in greater omentum. You have to write this in contents. Okay. Later, you have to write that there will be right and left gastroepiploic vessels. Right and left gastroepiploic vessels. Okay. See, epiploic meaning what? Epiploic means associated with the omentum. Simple meaning. That's how you will remember. Anything in the body, it has to have vessels, right? Anything which is living, which is in a body, it has to have a supply of blood. So it will have right and left gastroepiploic arteries and veins. Okay, these are the contents of the greater omentum. What are the functions of the greater omentum? All this you have to write in the exam. Yes, you cannot jump from this. Yes, what did I tell you? First point, storage of fat. That is the most gracious part. Okay, storage of fat. Very important aspect is it helps in preventing spread of infection. Why? I have written above only. Why? Because a lot of macrophages are present, right? Because of so many macrophages, whenever there's a foreign object or foreign body or foreign organism entering, macrophages will directly attack the organism, right? So many are present. Lastly, very important, write down, the greater omentum is known as the policeman of the abdomen. Okay, why is it known as the policeman of abdomen? Write down the reasons, two reasons. See, you will be thinking this is getting very extensive. Why is it telling all these functions? I'm giving you theory plus understanding, right? Take down notes now itself, right? You won't have another time. Finals are coming. That's why I'm with the class itself only. I'm telling you to write down notes. Directly from lecture notes, you can revise, right? So now in the policeman of the abdomen, what is the reason I'm telling you to write? Two things it will do. One is when there is infection, once there is infection, this greater omentum, that fellow will move toward that site. Did you understand? Wherever there is infection, at that site it will move, meaning moves towards the side of the infection, moves towards the site of infection, moves towards the site of infection. Did you write this first point? Another aspect, when there is perforation, what you will write, what this fellow does is it also moves to areas where there is perforation, meaning it does not move like it is not going specifically to that area. It is mobile, right? Our momentum is mobile. So whenever it finds infected area or perforated area, it will, when it boil moments are there, when the momentum is freely mobile, it will go and attach. Okay, it is a mechanism like that. It will go and attach, or it will get closer to these areas. That's what it is telling. So that's why when it moves towards the areas of perforation, so that there is no leak, there is no leakage, and there is no infection, so that macrophages can fight. That's why we are giving the name as policeman of the abdomen. Did you understand the greater omentum? Please let me know, please. We have talked about the.
Yes, Sadat, they've understood.
Thank you very much. There are other functions of the omentum also, greater omentum also, but we need not go in all that details. These three, if you write, you will get full marks. So functions, the contents, the attachments, and the diagram, okay, and the meaning of definitions and basic things. That's how you will get the marks. Simple. Now let's jump into the lesser omentum. Lesser omentum. Remember what was the lesser omentum? Remember? Yes, the liver was there, okay, and our stomach was there. That's all. Our stomach was there. Ah, sorry. 1 second. Yes. Okay. Now, what did I tell you? That omentum was coming, the parietal epithelium was coming like this, and he was coming like this. Like these two layers were coming like this, and it was attaching like this, and it was going in the diagram. In the diagram. So now I want to depict it in the anterior inferior aspect, right? We have to depict it. So now write down, everybody. Write down. What is it? What is the lesser omentum? First, write the definition. It is a two-layered fold of peritoneum covering the or attaching the liver and the stomach. Simple terms, you have written it down. Then side heading, attachments, where it is attached. Tell me where to where it is attached. In the diagram only you can see. Inferiorly, where it is attaching, tell me. Inferiorly, attaching to the lesser curvature of the stomach. Lesser curvature. I have told you to revise the gross anatomy of stomach and liver. Don't tell me you do not know the lesser curvature and the greater curvature. Finals are very near. This is the lesser curvature. This is the greater curvature. Okay. So the lesser curvature of the stomach. Okay. Inferiorly, you can see, right? It is going attaching over here. And also it will be attached to a little part of esophagus and duodenum. If you want to write, you can write. Otherwise, if you write only lesser curvature, you will get full marks. Don't worry. Okay. Now superiorly, where it is attaching? Superiorly, you can see, right? It is attaching to the liver. So superiorly, it is attaching to the liver. So in the liver, what is there? In the liver, I've told you to revise the anatomy. I'm telling you all the time. Whatever I tell you, you have to do that before the session so that it's helpful, right? You understand it easily. So this is the anterior aspect of the liver. What you will see, this is the right lobe, this is the left lobe. Okay. When I'm seeing the posterior aspect of the liver, what will happen? I'm drawing the posterior aspect. What you will see, this is the caudate lobe, this is the caudate lobe, and here is our most important aspect. Yes, this, you see this? Yes. What is this? What is this? Tell me, anybody knows? If anybody knows, I don't have time. Let's just jump into it. Ligamentum fissure. Okay, fissure for ligamentum venosum. Okay, and over here it will be porta hepatis. Porta hepatis. Okay, so where is this omentum getting attached superiorly from the stomach? This will go like this, right? So when we see the behind of the liver, it will go and attach in the green aspect. Do you see that green aspect I have drawn? Yes, where it is getting joined? It is getting joined into the fissure of ligamentum venosum and around the porta hepatis. So what you will write? Superiorly, where it is getting attached? You will write it is getting attached superiorly in a L-shaped pattern. L-shaped pattern containing the fissure of ligamentum venosum and porta hepatis. Okay. Till now, did you understand this? Did you understand the lesser omentum attachments? Everybody just let me know.
Yes, Sadat, everybody says yes.
Great, great, great. So now I have brought you diagrams. Wonderful diagrams I have brought you. You see this diagram? You see this diagram? Yes. This part, this, you see this whole thing like this? This is the greater omentum. Okay. This is the greater omentum. Now let's remove that. Okay. Now focus over here between the liver and this. Okay. Let's draw with yellow, not with yellow. Let's draw with orange. Okay.
Sir,
So do
can
you
you
see this?
zoom in?
No, that's the max, I think. Oh yeah, yeah, sure. Okay, so this is the stomach, this is the liver. Okay, now let's just rub this off. This attachment you see, right, from the greater curvature from here. Let's go down. Let's go down. Yes. Do you see this lesser omentum? Do you see this or not? Very nicely it is showing in the diagram. From the lesser curvature of the stomach, it is going and attaching to the superior aspect. Matlab the inferior aspect of the liver, where there is ligamentum venosum, fissure for ligamentum venosum, and porta hepatis. So superior attachment is that, inferior attachment is the lesser curvature of the stomach. So this is the lesser omentum. Okay, right. I think attachment you have understood. Now Just observe, my friends, just observe in this diagram, or I will just redraw the diagram for you. Just redraw the diagram for you just over here. Okay, this is the liver, this is the stomach we have drawn, right? Okay, this is the stomach we have drawn, right? Okay, now what I've told you, we know that at the last part, one second, at the last part, one second, sorry, I'm getting a bit, yeah, in the last part of here we'll have the duodenum, right? This is the stomach, this is the duodenum, right? So now what will happen is this omentum which is coming from above, this whole lesser curvature is covered or not? Yes, this lesser curvature is whole is covered by lesser omentum. Little part of it is attached to the duodenum also, I have told you, right? So now what I'm doing, what we have done as humans is we have divided this into two aspects. We have divided this omentum into two aspects. One is the hepatogastric ligament. Okay, organ to organ, right? Organ to organ means ligament will tell. Hepatogastric ligament, and then from liver to duodenum, we are telling hepatoduodenal ligament. Did you understand this? Nothing much. Okay, just simple it is there. See, in simple terms, lesser omentum is further divided into two. That is hepatogastric ligament, hepatoduodenal. Why? Because of the attachments. These are the ligaments. We are dividing the lesser omentum further. Us humans have a very nice habit of dividing and being very specific, right? So that's why they have become very specific, so that we understand that liver, from liver to stomach, hepatogastric, from liver to duodenum, hepatoduodenal, both are part of lesser omentum only. Okay, yes, this is the thing. Now write the contents of this, contents of the lesser omentum. They have given it in two ways, right? One way in the textbook which I have referred, Vishram Singh, they have given it in two ways. One way they have told about the contents in the lesser curvature manner, meaning near the lesser curvature of the stomach they have given contents, or they have given another way of right free margin of the lesser omentum. So what is the right free margin? Come back to this diagram, do you see this diagram? You see this diagram, right? Let's just remove all this. Okay, do you see the, what is the right part of this diagram? Tell me. This is the right part of the diagram. So now in the right part of the diagram, do you see this border? You see this border of the omentum? Do you see this or not? Yes, this border is free. Okay, and it is a very important landmark for surgery, for many pathological events also. Very important landmark. Not many pathological events, but for surgery very important. So we are giving this free margin of the omentum a name. Okay, we are giving this free margin a name called as right free margin. No scientific term. Right free margin of the lesser omentum. So this is a very important landmark. Also, this will come in foramen epiploicum also. So do remember this. Why I'm telling you to remember? It will come in foramen epiploicum. Okay, for the connection of lesser sac, greater sac. Remember that? Yeah, it will come here in the right free margin of the lesser omentum. It will come there. Okay, so now right free margin, what all will be there? Only all the things which are passing from the what do you say, porta hepatis, that is portal vein, hepatic artery and bile duct. Okay, all the aspects of the thing which are passing from the. So now when you look over here, this is our whole sorry, this is our whole lesser omentum, right? So now I'm telling you this border is free. This border, when you see this border is free, I'm telling. So you can see clearly, right? This porta hepatis, right? What are the contents? Sorry, it will not go downwards. One second, let's just move that. Yeah, only bile duct will go downwards. So now you can see, right? So hepatic artery is there, portal vein will be there of porta hepatis, and bile duct will go downwards. Over the duodenum. So that porta hepatis is present near the free margin, I'm telling. That's all. That's all you have to write in the contents. Right free margin, what you have to write? Portal vein, hepatic artery and bile duct. Okay. Near the lesser curvature, what is there? I have already told you, right? Lesser curvature, you know already. Right and left gastric vessels, right? Gastric arteries, as well as gastric nerve will be there. Okay. For people who are only listening to this class, after this session, go back to the chapter and just make notes for this. Okay, just make notes if you think you're not able to remember everything. Lesser omentum is over, greater omentum is over. Now let's jump into our mesentery. Nothing much is there in mesentery. Okay, what is mesentery? So in mesentery, what will happen is, I've told you, right? Mesentery, I have told you in the starting of the class, it will just descend and it will catch the viscera. But remember, I have told you just above, when we were classifying mesentery, we told mesocolon, somewhere we told, right? Yeah. So now mesentery specifically, now they have put specific a term to this as for the small intestine. For the small intestine, when the vessels come like this, we'll give the name as mesentery or mesocolon. Okay. Now, what is the important aspect of this with the posterior abdominal wall? See, this is the anterior part. This is the posterior part. This is the peritoneum, which will come like this. In the starting diagram we have shown, right? Let's go back to the diagram if you're getting confused. Where is our diagram? Yeah, you see this part, right? This part is going and engulfing the small intestine, so I'm giving this part a name known as mesentery. Okay, mesentery. Add in the diagram if you want. Okay, so the thing which is catching the small intestine from the posterior abdominal wall, we are giving the name as mesentery. So this fellow will have one attached border over in here in the posterior, and this is the free border we are giving. Okay, so now in the textbook what they've given is, or in the exam, how if they ask you mesentery, how you should describe in the aspect of attached margin what is there, and free margin what is there. Free margin, nothing much is there. Only in attached margin you should write that it is attached posteriorly from L2 to duodenojejunal flexure. That's all you have to write. Attached from L2 vertebrae to duodenojejunal flexure. Okay, what is in the small intestine? Tell me. You know, right? Jejunum and ileum. Right, jejunum and ileum, a part of duodenum also, but jejunum and ileum belong to this. So anything of peritoneum which is engulfing the jejunum and ileum, we are calling it as mesentery. Okay, now just bear with me for the another 20 minutes. Okay, I think it will be a long session, so 20 minutes if you bear, I will be finishing of the peritoneal cavity. Simple, over, it's almost over, and I will be finishing about the foramen epiploicum and Harrison's pouch, and then we will finish the session. Till now you have understood what is peritoneum, what are the layers, what is the coverings, what are, where it is getting attached. All you have to know now is how to present it on paper, which also I'm touching a bit about that. So here you have written about the attached part in the mesentery, and the free aspect, nothing much is there. Very, very important in this mesentery aspect, listen to me closely, mesentery aspect, you have to write about the contents in this, the contents which are passing in the mesentery. See, apart from the mobility and everything which is provided by the peritoneum, the most important, another important aspect, it is provides vessels, pathway for vessels, right? Pathway for vessels for uh, giving supply. So I'm telling you, the most important aspect of peritoneum in the mesentery is what is the contents. So write down the contents, everybody. Pranav, I'm audible, right?
Yes, Sadat, you're audible. Yeah.
Yeah. So just write down this superior mesenteric artery. Just bear with me, my friends. If you understand this now, you will never forget it till the end of the medical school of yours. Okay, so superior mesenteric artery is very important. Apart from superior mesenteric artery, you will have lymphatics. Apart from lymphatics, some nerves will be there. So what is the important, why did I tell you it is important over here? Why I'm telling you it is important is this lymphatics is a troublesome person over here. Clinical aspect, put star and put clinical aspect. What is the clinical aspect? See, when infections happen in abdominal wall, these lymphatics, if lymphatics get infected, they will cause obstruction in the small intestine. They will cause obstruction in the small intestine. So what will happen is, if you see in lymphadenitis or something like that, or acute appendicitis, also sometimes the lymphatics get spread. In those scenarios, what will happen is these lymphatics will get inflamed. These lymphatics will get inflamed and obstruct the mesentery. So these so obstruct the mesentery. How they will obstruct the mesentery? These lymph nodes are connected all around the small intestine. They are not only present in the mesentery. Okay, they are all around the small intestine, right? So they are connected together, right? Lymphatics are connected together. So this whole thing, they will get inflamed and they will obstruct. So that's how the person will get affected. Either you will see it in acute appendicitis or lymphadenitis, mesenteric lymphadenitis. You can give a name, mesenteric lymphadenitis. Denitis means spread. Lymphangitis means localized, it will be lymphadenitis. Okay, denitis. Wrote this down? Yes, over. Now we have done with, you are done with this. Okay, we are done with this. Now let's jump into the peritoneal cavity. Okay, peritoneal cavity. What is the peritoneal cavity? I have told you. It is the space between the parietal peritoneum and the visceral peritoneum. What will it contain? It will contain parietal fluid. Where is that parietal fluid coming from? From the mesothelium of the peritoneum. Okay, mesothelium secretes that, right? So now greater sac you have understood. Greater sac you don't have to jump about it. I just want to come to a very important aspect of how there are certain areas that are divided in the human body. So if you see, this is the human body, this is the diaphragm, okay, this is the diaphragm. Okay, so now if I draw the liver over here like this, okay, and the stomach like this, okay, the stomach like this, and the me and the yeah, you have revised the gross anatomy, right, everybody? Yes, this is the ascending colon, transverse colon, descending colon. Okay, don't make me remind that all that you have understood all this, right? Transverse colon, descending colon, right? So now why am I drawing all this? See, there are certain spaces, there are certain paracolic gutters. What do I mean by gutters? Gutters are also meaning spaces. Okay, if you want to remember this, you can remember, my friends. If you do not want to remember this, you can neglect this also. If somebody is attending session for the sole purpose of examination, you do no need to remember. So below diaphragm there are certain spaces, so that spaces are known as subphrenic spaces. Subphrenic spaces. Okay, subphrenic means below diaphragm, subphrenic. So here you see this aspect, one name I should give. Here you see one name, here you see one name, here you see one name. Till here did you understand? This is the write down. Whoever wants to write this down, write anterior, sorry, when did I write anterior? Yeah, right anterior subphrenic space. Did you understand this? Sorry, one second. Subphrenic space. Did you understand this? Right subphrenic space, right anterior subphrenic space. Here you will have left anterior subphrenic space. Here you will have right posterior subphrenic space. Here you will have left posterior subphrenic space. Why am I telling you this spaces? What is the purpose of me telling you the spaces? See, there is a very important question, I may say. If you do not know the importance of this space, right posterior subphrenic space, is given a name. What is this right posterior subphrenic space? Harrison's pouch. Sorry, not Harrison's, Morrison's. Sorry. Yeah, Morrison's pouch. Morrison's. Only one R is there in this guy's name. Morrison's pouch. Okay, Morrison's pouch. Okay, this is a very, it's a VSAQ. Okay, it's a VSAQ. Or if you want to know this space, it's interesting. Okay, this one space, did you understand? Right posterior subphrenic space. Apart from these subphrenic spaces, we have other thing, how it is divided, how abdomen is divided. Last, my friends, last. After the spaces, I will just jump into the two things and then we are done. Okay. So now you see this ascending colon, you see this transverse colon, you see this descending colon. Okay. Yeah, Pranav, if you could just forward the review forms to the WhatsApp group.
Yeah. Okay, sir. Yeah.
Thank you. Supracolic, infracolic. What do I mean by this? Supracolic, infracolic, right paracolic, gutter. Gutter means gutter. Okay. Left paracolic, gutter. Students who are wanting to know this, you can know this. Otherwise, if you just know what is supracolic, infracolic, that's more than enough. Okay, so now in this diagram, with respect to transverse colon as well as the rest of the colons, transverse colon, when you look above, we are dividing it into the supracolic compartment, below transverse colon, infracolic compartment. Did you understand this? Yes. Ascending colon, right side of the ascending colon, we will give a name as right paracolic gutter. And in the descending colon, the left area, we are giving a name known as left to paracolic gutter. Did you understand the spaces and the gutter, supracolic, infracolic? Pranav, just let me know. Then I will jump into the two last part of the session and then we are done.
Yes, Sadat. Yeah.
Very good. Okay, now everything is done, my friends. The only thing now it is left is for you to take down notes is for hepato. Not hepato. The thing you have to learn is
Sadat, someone wants to repeat boundaries of paracolic gutter.
Yeah, paracolic gutter, nothing. See, if you see over here, what I've written here is, this is the ascending colon, right? See, we have given this the name as infracolic gutter, so we need not give another name for this, right? So a little space is present at the right side of the ascending colon. Okay, ascending colon is present on the right side. Again, a little space is present in the abdominal cavity. We'll have to give names as human beings. So we have given the name as right paracolic gutter. In the descending colon, there is a little space. It is present already in the left side. Again, left side there is a little space. Then we are giving the name as left paracolic gutter. Simple. With respect to transverse colon, supracolic, inferior to it, infracolic. Okay. These compartments you should just know. Just for your understanding. Okay. Everything is given a name, right? So for your understanding. Now the only aspect left for you to take down notes is for lesser sac. I will give certain little amount of notes. Lesser sac, Morrison's pouch. Little notes I will give and a diagrammatic a little bit representation. Lastly, foramen epiploicum, or otherwise if I'll explain this foramen epiploicum first, then let's go to the easy parts. Okay, foramen epiploicum, let's come to that. Okay, now foramen epiploicum, let's write it down. What was the other name? Tell me. Foramen epiploicum, Winslow, right? Winslow, foramen of Winslow. Why Winslow? This fellow has discovered the area. Okay, remember I told you the importance of this is what? It connects the greater sac with the lesser sac. Yes, first point is this, connects the greater sac with the lesser sac. Next, what you should write? You should write one important point. It is located at the level of T12 vertebra. T12 vertebra. Okay, write this down. It is located at the T12 vertebra. Okay, you need to know the location, right? T12 vertebra. A little above only it is present, near the liver. Okay, what was the third important aspect I had told you today? Remember the right free border of the lesser omentum? You remember or not? You remember, right? Okay, so now what did I tell you? Foramen epiploicum comes in this area of free margin. Okay, I think if you people have forgotten about it, I will just draw the stomach. Okay, right. So remember the omentum like this, right? This was the omentum. I had given this omentum, this border a name. Remember this border? This is the free border. So near this free border, there are certain aspects. What is that aspects I'm talking about? We need to write about the boundaries. Okay, boundaries of what? Foramen epiploicum. Why are we writing the boundaries of foramen epiploicum? Because we need to know the boundaries of the foramen which is connecting the lesser sac with the greater sac. So in the 3D diagram, I will be showing you with anatomy. If people are staying back, I will show you all the things. So now in the foramen epiploicum, what you will know is, see, I will draw the foramen. I have the diagram. If you want me to show, I'll just show the diagram, then I will write the boundaries. Okay. Yeah. You see this diagram, my friends? Let me just rub this off. Yes. Okay. Now you see this a little bit of black color line. You see that black color arrow going. You see that? You see this? Yes, you see that, right? So that is the foramen. That is the foramen. Let me depict it with a nice color, bright color. So you see this foramen? Yes, that foramen connects the. This is the greater sac. Okay, this anterior part it will be present. So this greater sac connects with the lesser sac which is present in the posterior aspect, as in the sagittal section we have already seen, right? So now I'm just giving the boundaries to this foramen. Why am I giving the boundaries? As you can see in the boundaries, because we need to know. I will tell you the importance also. So you can see the boundaries. Anteriorly, I have told you already, right? The porta hepatis, right? Portal vein goes anteriorly, and hepatic artery as well as bile duct goes down below. We have already dealt with this in the free border, right? So let's write that down. Let's write that down. Where was that? Yeah, boundaries. So what I have told you, anteriorly what was there? Anteriorly we have the hepatic artery and we have the let's draw it brown. This is our bile duct, and post a little bit behind, still anterior to the foramen, these three are together. These three are together present in the anterior aspect. So write down anterior what is present? Three. Portal vein, hepatic artery, bile duct. Did you write this down? Yes. What is there posteriorly? If you imagine if you could just imagine for me, if you could just imagine, there will be inferior vena cava like this. Inferior vena cava. Okay. Posteriorly. Okay. Near the foramen. Okay. And then when you see superiorly in the diagram also, if you want me to take, I will take you there. Just wait for a second. Superiorly what will be there is, our liver will be there. Our liver will be there, right? Free margin. Our liver will be there. What part of liver will be there? Caudate process of caudate lobe. Caudate process of caudate lobe. I'll come to that. Meaning caudate lobe is present. Okay, caudate lobe is present. One second. Superiorly, what is there? Caudate lobe is present. Posteriorly, what is there? IVC, inferior vena cava is present. Anteriorly, what is there? Portal vein, hepatic artery, and our bile duct. Inferiorly, just write that this hepatic artery fellow will come like this and will go like this. So there will be a horizontal part of this artery. Okay, horizontal part. Actually, this diagram is like a sagittal section, right? I cannot show that this part as a sagittal section in a sagittal section. It's actually going that way. Okay, for your understanding, I'm telling you it goes below the foramen. That's why we are writing it down in the inferior part. So once again, in the inferior part, what you should write? Horizontal part of the hepatic artery, and you should write another thing, duodenum. Okay, duodenum will also be there, right? Below stomach, what is there? Duodenum, right? Now, what have I explained? This was the liver, this was the stomach, this was the lesser omentum. Near the free margin, what have we dealt with? Superiorly, there will be caudate lobe. Inferiorly, what we have dealt with? Inferiorly means here somewhere. Hepatic artery as well as a part of duodenum. You see this duodenum, right? Hepatic artery and duodenum. Anteriorly, we cannot draw in this diagram, right? Anteriorly, we have drawn the three vessels, and posteriorly, we cannot draw in this diagram. We have drawn it over here, IVC. Just let me know, Pranav, if they have understood this foramen, please. Kindly just let me know.
Yes, Sadat, they've understood. Yeah.
Everybody has understood. Nobody is there.
Yeah, all yeses. Yeah.
Great. I have wonderful students over here today. Right. So I think you have understood the foramen of epiploica. Okay. Certain part in clinical aspect, if you have to write in the exam. In the exam, all you have to write is it's a VSAQ. Sometimes they may ask it in within an SAQ. If they ask in an SAQ, you can write the clinical part. Yeah. What is the all the things you have to write? First, you have to write it is the foramen connecting the lesser sac with the greater sac. Then you have to write about the boundaries. All the boundaries nicely you draw, and then nicely you mention. Give spacing. Okay. Don't write congestedly. Give nice. Take how many ever pages you want. First you write the definition, then you write it connects and all that, then a whole half page diagram or one page diagram, your wish. Then here boundaries you write, give lot of space. Okay, that's the interesting part. You give lot of space so that the examiner understands. And yeah, clinical aspect, if you want to add, just write one keyword. I will tell you, just write it down. Internal hernia. Okay, internal hernia. What is hernia? Hernia means our abdominal intestines or something comes outside in some cavity, some perforation or some cavity has formed, abnormal cavity. Okay, it's not normally present there, or some perforation is there, that small intestine will move outside. Already this small intestine is full like this, right? If somewhere there is perforation, it will move outside, right? So what is happening in this internal hernia is through this foramen it will enter into the lesser sac. Okay, it will enter into the lesser sac. Sometimes in the greater sac, if the pressure is more or some he was tilted upside down or something like that, some event will happen, so the intestines will move into the lesser sac. So this name we have given as internal hernia. There is there is surgery or something is there for this, so we need not go into that. Just remember that internal hernia happens with the foramen. Okay, now we are done with the foramen. Now easy parts. What was there? Lesser sac and our that Morrison's pouch, right? So lesser sac, what did I tell you? Lesser sac, you already know about this. Lesser sac. One second. Yeah, so lesser sac. Sorry for the disturbance. So in the lesser sac, you know what is the lesser sac? Let's go back to the whole our top diagram, our most favorite diagram. Yes. Do you see this diagram? Do you see this diagram? Yes. Now tell me, if I tell you what is the anterior attachment of the lesser sac. Anterior means, you know, in the diagram, this is the anterior, this is the posterior, right? So the sagittal section. So anterior attachment, what is there? Okay, it's getting very congested. So let's just put the liver over here, put the lesser sac over here. That's all. Stomach over here. Okay, so liver, stomach, and let's what else should we put? Yeah, let's put the lesser omentum and the greater omentum. Okay. So anteriorly, lesser sac, what is the boundaries? You should write caudate lobe of the liver. Okay, caudate lobe of the liver, lesser omentum, greater curvature of the stomach, greater omentum. Did you understand this? Have you understood this, my friends? Anterior attachments.
No answers yet. Yeah, they have understood.
Great. So this is the anterior, this is the posterior. Anterior attachments are first caudate lobe of liver. Okay. See, you have to visualize or you need to revise the notes. There are two things. Either you explain it to yourself or you revise the topic through your notes, okay, or you visualize. Visualize means you can see through the anatomy apps or something. But see, Peritoneum, there are not many good visualizing apps or visualizing diagrams. What you can do is you can explain it to yourself through the sagittal section. I prefer sagittal section is the best way you can explain it to yourself so that you can understand. Okay, so caudate lobe of the liver, then you have the lesser omentum, then you have the stomach. What stomach? Greater curvature. Okay, lastly you have the greater omentum. These are the anterior attachments. What is the posterior attachments? Remember that posterior attachments. Let's go back to the diagram. What do you see in the posterior attachments? Nothing is there actually. You can say it's all getting. You can tell it as transverse colon, transverse mesocolon, all this attachments. Anteriorly you can tell this. Posteriorly they're telling it like this. But if you have actually visualized, it is just getting into the root. It's just folding off, right? There's no specific attachment. So you can just tell posterior two layers of the greater omentum are present. These two layers of the greater omentum is present. If you want to mention other things in the posterior layer, you can mention transverse colon. So what have I told you about the posterior aspect? Posterior aspect, nothing is there. You have to only tell that these two layers are coming this behind. Which two layers? Posterior aspect. What you have to write? Two layers of the greater omentum. And if you want to write, I mean, you can tell that these two layers are engulfing the transverse colon and mesocolon also. Okay, these two, it will engulf and it will come. Okay, this is the posterior relations. Okay, that's all. Anterior wall and posterior wall attachment. These two only you have to tell. Okay, there's nothing much. Lesser sac is over. What is there next? Morrison's. Why am I telling it Harrison's? Morrison's pouch. Yes. Remember what did I tell you? What was Morrison's pouch? Right? Posterior. Tell me. What was that? Subphrenic space, right? Subphrenic space. Subphrenic space. At the end, my handwriting gets a bit problematic, but kindly manage. Subphrenic space. Okay, just give me 5 minutes. It's over, my friends. Please bear with me. So now, what have I told you in the right posterior intraperitoneal, right posterior subphrenic space? Remember the diagram? Where did the diagram go? If I could just find the diagram a bit fastly. Yeah, you see this pink box? Where is it? Where is it? Where do you see the pink box? You can actually see it below the liver, and you can actually see it like you can see it, like you can visualize it, right? So now I just wanted to visualize this space. Visualize it anterior to posterior. I wanted to visualize even the kidney also. So now, how am I drawing the diagram? I think if you are able to understand, just let me know. This is the anterior aspect. Okay. This is the kidney, right kidney. Okay. This is the liver. This is the kidney. I hope. Are you understanding? This is the posterior aspect. I'm drawing it like this. Okay. I'm drawing it. I don't know what name should I give to this section. I'm drawing it like this. I hope you understand. So now in this space, what is happening is we are giving this. There's a pouch. There's a pouch like this. Okay. There's a pouch like this. Now what is the borders of this, boundaries of this? Anteriorly, when you look in the anteriorly, if I just color this box, anteriorly what is there? Write down. Anteriorly in the Harrison's pouch, you have posterior inferior aspect of the liver. है ना? Posterior inferior aspect of the liver. Take a screenshot of this diagram otherwise. Then posteriorly what you have? Posteriorly you will have a kidney. Okay, kidney just one layer of covering of the peritoneum. So posteriorly you will write, this is the posterior, this is the anterior. Again I'm telling. So posterior what you will write? Kidney, right kidney covered with peritoneum. Okay, peritoneum. One layer. It is not a peritoneal organ. Okay, so kidney, right peritoneum. That's all. Posterior boundary. What is the superior or what is the above thing? Above thing you can just write the coronary ligament. A coronary ligament is there of the liver only. Coronary ligament. Okay. Now inferiorly what is there? Transverse colon or mesocolon. They will go like this. Transverse colon, mesocolon. Okay. Transverse colon or mesocolon. So let me just revise. Anteriorly what is there? Posterior inferior aspect of the liver. Posteriorly what is there? Kidney is there and a little bit of peritoneum covering it. Superiorly what is there? Superiorly or above you have coronary ligament, and inferiorly what is there? Inferiorly you have transverse colon and mesocolon. I think I've covered everything. Now just let me know if there are any doubts.
Sadat, they had a doubt. They actually wanted you to explain about the subperitoneal and preperitoneal organs.
Oh, about the retroperitoneal and peritoneal organs.
Extraperitoneal are divided into, retro, infra, peri.
Yeah. So there is nothing more yeah, if just ask them once again if they want me to explain the Douglas pouch. Do you want me to explain the Douglas pouch, students? How many are there over here? Only the boundaries I have to explain.
Okay, they want you to explain Douglas pouch, yeah.
Yeah, I'll come to that. Let's just clarify this doubt. See, initially during the development, when the peritoneum covers the organs, okay, this is the organ getting covered. Okay, this yellow aspect is covered by the peritoneum. Okay, so now I will name this as peritoneal organs. What will happen in certain organs is they will not at all get covered. They will not at all get covered by the peritoneum. I don't think there are no organs like that. Okay, all the organs, what is happening is initially they will be in the peritoneum. Initially they will be in the peritoneum, like this mesentery peritoneum. But what will happen is this you see this layer. Let me color this layer. You see this layer, my friends? Do you see this layer? Yes. Now what I'm doing is this is the posterior abdominal wall. Okay, this is the whole thing we have discussed from the starting. I'm telling you, this green aspect, if you see closely, it will get pushed towards the posterior wall. This fellow is coming like this, green person. So now what will happen? Like this. Okay. So now this is this. This is the green layer I was talking about. This part. It's still moving. It's still moving. Now it is getting going and attaching to this. Yes. Did you understand this? What happened over here? What happened over here? The visceral peritoneum gets attached to the parietal peritoneum for certain organs. Okay. So what will happen when this happens? Only one-sided area of it is getting covered by the peritoneum. So I will give a name to these organs called as retroperitoneal organs. What are these retroperitoneal organs? Very famous organs are there, right? If you can see in the diagram also, I've explained the pancreas was there. Okay, the spleen is also there. Okay, not the spleen, kidneys and the pancreas. So what are all the organs? Write it down. Kidneys, what are these organs I'm writing? These are the retroperitoneal organs. Okay, suprarenal glands, kidneys. Okay, these are the primary retroperitoneal. Mean initially during the development only they will, these are the primary. During development only this process of if you want more further details is given in the book. This process of absorbing of the visceral peritoneum to the to the parietal peritoneum into the posterior wall is known as zygosis. Okay, that's how they become retroperitoneum. Okay, so now primarily kidneys and suprarenal. Secondarily means after development, after few days, these organs will become during the development become secondarily retroperitoneal. So pancreas, cecum, okay, and I don't want to confuse you guys, but in the textbook they have given duodenum some part. Okay, they're given duodenum some part and something like that they will give. So I think we need to avoid duodenum over here. Yeah. Apart from that, you have ascending colon and descending colon. Okay, cecum, ascending colon, descending colon, pancreas, these are secondarily retroperitoneal, means they will take time to become retroperitoneal. But when we see the kidneys and the suprarenal glands, they are initially in the development only. When the viscera is pushed into the peritoneum, they get excluded. I hope that doubt is cleared. Now where was I? In the Douglas pouch. Okay, with the Douglas pouch also, I told you I will explain you the importance of all the foramen epiloicum. I have explained you the importance of the inguinal hernia, internal hernia. Whereas about the lesser sac, we don't have to discuss. About the Douglas pouch and the Morrison's pouch, these two pouches, there is a certain clinical significance. Listen to me closely. Douglas pouch, let's go. There is nothing much to explain. Douglas pouch seen in where? Tell me. Pranav, just let me know. Douglas pouch, what are they telling? Where is it seen? In which people there it is seen?
No answers yet. Yeah, in females.
Females. Very good. What was the Douglas pouch I have told you? It is the rectouterine pouch. Now, in the Douglas pouch, it's a very important VSAQ. You can see within the diagram itself, what are the boundaries? What is the anterior border? Tell me, what is the anterior border? It is the uterus. As you can see, what is the posterior border, my friends? Posterior boundary, it is the rectum, as you can see in the diagram. And I don't think superior and inferior, if you need, once again, let me just check if I have written the notes for the superior and inferior. Oh, yeah, I think Yeah, I think they've not given. So now uterus anteriorly, you can see in the diagram. Okay, if you want, I have made an other diagram also, rough diagram. Yeah, here it will be better. There it is very, this recto-uterine pouch you can see, right? So anteriorly you have the uterus, posteriorly you have the rectum, inferiorly what do you have? Inferiorly what do you have? This pouch, right? This space. So they are giving that space as, I don't know, fold of the peritoneum, something like that they have given. Okay, but for understanding only anterior and posterior is enough. Okay, what is the importance of this? See, the importance of this is about the Douglas pouch. Write this down, everybody. What is the importance? See, there are certain things about standing upright and sleeping, like supine position. Okay, in upright position what happens is, Douglas pouch is the, in females, Douglas pouch is the most dependent cavity, most dependent aspect of the cavity during upright position. What do I mean by most dependent? Most dependent means that most dependent, once again, yeah, most dependent means that whenever you're standing upright, all the fluid in the peritoneum will enter into this pouch. Did you get it? Did you get it? Most dependent means at that particular time, the whole fluid of the peritoneum goes into this particular part. That's why we're giving the name most dependent. In the supine position, okay, the another differentiating point is, here it is in the peritoneal cavity. Okay, peritoneal cavity, it is the most dependent part. Whereas when you are in the supine position, this Douglas pouch is the most dependent part for the pelvic cavity. Pelvic cavity. Write this down. It will take some time to process this information, but just write this down. So Douglas pouch, upright position, most dependent part in the upright position for peritoneal cavity, whereas in supine position, most dependent part is the Douglas pouch itself for the pelvic cavity. Okay, what is the meaning of most dependent part? All the fluid present in that peritoneum at that particular time when you're standing. In the peritoneum, the most dependent part is the Douglas. When you are sleeping down, when you're in a supine position, most dependent part of the pelvic cavity is the Douglas pouch. Okay, this is the important aspect of the Douglas pouch. And lastly, Morrison's pouch. Morrison's pouch, you have to write that when you're in the supine position, this is the most dependent part for the peritoneum. There we have written for the upright position, right? But Morrison's pouch is for the supine position. Okay, did you get this? I think Nusrat can stop the recording.
Sadat,
Yeah, this is
This
a colon. This is
conference
our
will
transverse
now be
colon.
recorded.
Yeah, this is our transverse colon. Let's remove the transverse colon also. And this is our greater omentum still. I have not removed everything. Right. Now you can see that this is our visceral peritoneum. Do you see all this? The whole of the abdominal organs are lined by this. Let's hide the visceral peritoneum. Now you can see clearly when I go above, do you see this below the liver? As you can see, this is our lesser omentum, hepatogastric ligament. Do you see over here it is written in the right top corner? Do you see that? Hepatogastric ligament. Why? Because it is attached to the stomach. When you see over here, this is still the lesser omentum, but the hepatoduodenal, because it is attached to the, once again, yes, you can see, right? This is the duodenum, this is the stomach, and that's how we can tell this is the hepatoduodenal and this is the hepatogastric ligament. Okay, let's remove this and let's proceed forward. Now, sorry. Yeah, now we are done with this lesser omentum. We are done with the greater omentum. What else is left? Let's see. As you can see, is there anything else you want me to show you guys? The greater sac and lesser sac is not there in this anatomy app. Otherwise, I would have shown you like this in the sagittal section like this. We can tell you that. I will just draw draw it, and then I think you will understand. Let's just dissect this out. Dissect. Oh, sorry, the little part of liver is also gone. So now I'm just drawing and telling you what is the greater sac. So the whole greater sac will come. 1 second. Yeah, the whole greater sac will come like this. Can you see in the sagittal section we have seen whole, it will come like this. It will go near the stomach, it will go here below, it will go still below. Here the urinary bladder. From there it will, let's go. I think it's not moving. From there it will come like this. From urinary bladder it will cross the kidney, and then it will go above like this, and it will engorge all this small intestine, and then it will come like this above, and then it will come and join like this. Okay, if you're it's, the diagram is not moving, otherwise I would have explained it very nicely. Let's draw the lesser sac. The lesser sac will be here like this. From the liver again it will go like this, it will engulf all this like this. Okay, I hope you have understood this. Simple. Okay, that's how the sagittal section was there. I'm sorry I'm not able to show you very nicely, but I think you will get the idea, right? This is the sagittal section we have seen, right? Okay, I think that's it. A greater sac, lesser sac, the momentums, and if there is anything, just let me know, Pranav, if they want me to show anything else.
Okay, you can type it in the chat box if you want to see something. Pouches, they want to see pouches.
Pouches. Oh yeah. One second. I think I don't know if they've shown over here clearly. The peritoneum pouches. I don't think they have shown over here. If you want me to draw, I will show you. One second. Let's just remove this. Dissect. Let's go. Yeah. So now if we go a bit below, still below. Let's remove this. Let's remove this. Yes. Do you see this? Yeah. Yes. So now I think we can see clearly. Okay, one second. Yeah. What is this? Our bladder, right? So I will just draw and explain to you. This is a bladder and this is our rectum, right? So simple. This is in the male, right? In the male. So let's just dissect this also out so that we understand very nicely, right? Now it's clear. So now let me just draw and explain it to you very nice. Yeah. Let me just start drawing. You see the green aspect of the drawing. So the peritoneum comes like this, and it will just engulf a little bit above of this urinary bladder, and then it will go behind, and near the rectum it will form like this, a pouch. So now what have I given this name of the pouch here? What is the pouch? Rectovesical, or yeah, rectovesical pouch. Rectovesical pouch. Oh, the handwriting is really bad over here. Okay, so do you understand this? In females, what will be there? The uterus will be there. The uterus will be present like this. So the peritoneum will come like this and another like this. So this was the uterovesical pouch, and this will be the recto-uterine pouch or the Douglas pouch in the females, right? If the uterus is here like this. I think you have understood the pouches also, my friends. Did you understand it or not? The whole thing was like this in the sagittal section only. Pranav? Hello?
Yeah, yes, Sadat. Yeah, they've understood. Yeah.
Yeah, okay. You can continue. I'll stop sharing my screen.
Okay.
Yeah, I hope all the students have understood the peritoneum. I really